Okay, so we're on the last video of this series. So in this one, we're gonna talk about some more specific concern for epidural and spinal techniques. So first, we're gonna talk about epidural, and then we're move to spinal. So we can really do epidurals at any level of the spine, but we do them mostly for procedure of the lower limbs, pelvis, perineum, and the lower abdomen. Keep in mind that we're not violating CSF with epidurals. So the risk of cord injury is minimal unless we insert the needle too deep. So we can do, thoracic epidural, lumbar, cervical epidural, and we just go to the epidural space. We don't violate the dura and we don't enter the cerebrospinal fluid and hitting the cord. Its most common use, though, for epidural analgesia, as you probably know, is maternal analgesia for labor. Epidural analgesia can supplement general anesthesia, which eliminates or really reduces the need for deep levels of general anesthesia. So we get a more hemodynamically stable operative course. It provides effective post-op pain control and more rapid recovery from surgery because we're not under deep general anesthesia, so they wake up quicker, and afterwards they have better pain control, so they tend to participate in physical therapy and get out of bed more quickly and go home sooner. Epidural analgesia or anesthesia also reduces the adverse physiologic response to surgery, like autonomic hyperactivity, cardiovascular stress, increased metabolic rate, pulmonary dysfunction, and immune system dysfunction, and is especially useful in patients with severe pulmonary disease. Thoracic epidural anesthesia has been shown to decrease the incidence of MI and post-op pulmonary complication and to promote the return of gastrointestinal motility. There are well-controlled randomized trials that have shown that the perioperative use of epidurals for anesthesia or analgesia may actually reduce overall mortality and morbidity by about 30% compared with general anesthesia alone, where opioids are used as a sole mode of analgesics. Neuraxial blockade reduces the odds of DVTs by about 44%, PE by 55%, pneumonia 39%, and respiratory depression by 59%. So, how do we place an epidural catheter? Appropriate patient positioning is one of the most important things in placement of the epidurals. For the obese patient, the midline sitting approach is usually easier than lateral decubitus position. Oxygen by mask should be administered before sedation, where we use incremental dosing of sedatives like midazolam and or fentanyl. EKG, blood pressure, and pulse ox monitoring are the absolute minimum requirements. There are prepared sterile disposable epidural trays with stylated 2E needles, which are curved tip needles to reduce accidental dural puncture, have made the prep pretty straightforward. The spine is prepped and draped in a sterile fashion. Different techniques may be used to identify the epidural space, usually loss of resistance to air or saline. That's the most common approach, but we can also use ultrasound. The most commonly used approach to the epidural space are midline and perimedian though. To ensure that the catheter is not misplaced, like being in the subarachnoid, intravascular, or subdural space, we typically do a test dose, and it's usually 3 cc of 1.5% lidocaine with 15 mics of epinephrine. So if the catheter is too deep, it's in a CSF and we don't know it, the 45 milligram of lidocaine, which is 3 cc of 1.5%, which is 15 milligram per cc. It causes a temporary bradycardia, hypotension, and paralysis depending on the injection level. If the catheter is in a blood vessel, the 15 mics of epi will cause tachycardia, T-wave depression or inversion, and the lidocaine in there will cause tinnitus, perioral numbness, and metallic taste. So here's a video of doing an epidural catheter placement in probably low thoracic level. As you can see, the area is already prepped and draped. They're numbing up the skin with a little bit of lidocaine first. And the 2E needle, the curved tip needle, he's inserting it based on where he felt the space between the spinous processes were. Now he hit the ligament. Then the ligament is ligamentum flavum. And once you've hit the ligament, it's very characteristic. It's much harder, and the 2E needle doesn't move nearly as much. So he put in his loss of resistance syringe to it. He's just pushing to see if there is a give. And you can see when he's pushing in, there is a bounce back Now he's approaching, he got to the epidural space, and you saw as he's pushing air in there, he keeps going. Now he's confirming it with saline to make sure, yes, that was loss of resistance. And the next thing to do would be to put in the catheter through the needle and then taking the needle out. And he's doing that now. And when the needle's out, then he injects his test dose of lidocaine and epinephrine. And if it's negative, we put some tape on. And that's it. We're done. And the bleeding you see, that's really bleeding from the skin. It's not epidural bleeding, because that would be devastating. And it would actually not show up on the skin. That would be extremely rare. And the bleeding from skin is not a big deal. So that was it with epidural. Let's move on to the spinal anesthesia now. For spinal, or intrathecal is the other name for it, we do a single injection of local anesthetic into the subarachnoid space where there is CSF, to create a sensory, motor, and autonomic blockade of the nerve roots and spinal cord. It's typically indicated for procedures below the diaphragm because, as you can imagine, if it paralyzes the diaphragm, you can't breathe. We do spinals most often for total joint replacements like total knee arthroplasty, GYN procedure, or urologic procedure. It can benefit patients with cardiac or respiratory disease because it avoids or really lowers the risk of many adverse effects associated with general anesthesia, like cardiovascular and respiratory depression, aspiration, incompetent airway, and inadequate ventilatory drive that could cause hypoxemia. Patients with a history of airway problems, difficult intubation, reactive airway disease are also good candidates for spinal anesthesia because of its shorter recovery time, minimal drug exposure, and possibly reduced blood loss related to sympathetic blockade. Bupivacaine is the most commonly used agent and is almost always combined with an opioid, usually morphine or fentanyl. The opioids both make the onset of anesthesia quicker and make it last longer. When we inject the local anesthetic intrathecally, it comes into direct contact with the spinal cord. And as you can imagine, with its unmyelinated fibers, the drug is effective at a fraction of the dose that would be effective for epidural or IV route. So very small doses will go a long way. Currently, commercially available preps, disposable spinal trays are available, which make the prep and draping and starting the spinal quite nice. Prep and positioning is similar to epidural, and we typically use the L3, L4 space or L4, L5 space for insertion site because it's easier and there's no spinal cord there, so if you go too deep, we won't injure the cord. We avoid any levels above L1, L2 because of the spinal cord, and you can even use catheter or continuous spinal anesthesia, especially in palliative care, but we don't really want to do this very often because of the risk of infection and post-dural puncture headache. In this video, you can see the spinal for a toddler or a big baby. So you can see he's feeling the iliac crest, and the line that touches the iliac crest would be equivalent to around L4 level. So he's feeling the spinous processes and finds a space between the two. And the skin is, I assume, numb, or the patient's under anesthesia. So he's going straight in. And once you hit go through the ligament and hit the dura, you feel a pop. Once that happens, you see spinal fluid leaking out. And usually you don't want it to leak out much, so you cover it up and then inject your spinal injection of local anesthetic. And that's happening now. And at the end of the injection, you want to pull back a little bit to make sure you were injecting the whole thing in the spinal fluid. And he's doing that now. Then you take the whole thing out, and you're done. Okay, so we did our spinal or epidural for procedure, and now we're all done. Now what? We absolutely have to continue with the continuous monitoring of heart rate, blood pressure, and pulse ox. After spinal or epidural injection, vital signs should be monitored every 5 to 15 minutes until the patient's stable, because they can cause significant hemodynamic changes. Patients with epidural infusions, if you have a catheter, they require support, and the peri-op team should be aware of its planned use. So how long are we planning to leave it in? This ensures that the perioperative thromboprophylaxis, like low molecular weight heparin, Novanox, all that stuff, Anticoagulation, antiplatelet therapy can be appropriately timed. Suitable personnel should escort the patients who are going for tests while the epidural or spinal catheter remain in place. A significant advantage of the epidural catheter is the ability to continue pain control after the surgery is done, with minimal use of any systemic opioids, if any. A continuous infusion with patient-controlled infusions, the specific pumps, those are called PCEA. So for IV, it would be PCA. For epidural, it would be PCEA. And we usually order a continuous infusion of a low-dose local anesthetic, like 1/8% or 1/16th of a 1% bupivacaine, at about 5 to 10 ml an hour, with patient demand dose of 1 to 2 ml every hour. But we tend to modify these settings based on the patient's response. So if the patients have no sensation, it's hypotensive, we lower the dose. If they're having a lot of pain, we up the dose, and so forth. Larger nerve fibers, as you can imagine, recover quicker than the smaller ones. So motor function, which is usually conducted by the largest nerves, tend to come back before other function. As sensation returns, the patient detects light touch and pressure before temperature and pain. Motor function and sensation generally return from the hip to the feet, with higher dermatome levels recovering first. Motor function can be assessed by asking the patient to wiggle his toes or flex and extend his toes. The level of blockade should be documented in a dermatomal chart, as you can see in this picture. To evaluate the level of sensory block, we can use a cold object like an alcohol swab or ice in a glove. That's my favorite. Patients may believe that their legs are flexed or elevated when they're actually lying flat because of loss of proprioception. The brain kind of remembers the last leg position before the block went in and doesn't know where the limb is right now. Proprioception returns with the return of sensation. So it's important that limbs are not allowed to be placed in unphysiologic position and kept away from anything that can harm them or burn them. The catheter insertion site should be inspected to detect leaks, hemostasis, and catheter migration. And in addition to performing routine post-op observations with respiratory rate, blood pressure, and heart rate, observations specific to epidural analgesia should be made and recorded as specified on an epidural assessment chart. Observations are initially hourly for 4 hours and then every 4 hours. And we continue it until 8 hours after removal of the epidural catheter. The appropriateness of continuing an epidural should be reviewed daily, so we don't leave a catheter in for 20 days. That would be crazy. And alternative analgesia should be in place prior to removing the epidural. The catheter should be removed with careful planning of anticoagulation because, as you remember, insertion of a catheter can cause bleeding. Also, removal of catheter has the same risk. So that's it. Here are the references for the talk. I hope you enjoyed it, and thank you for listening.